Well, we all know about GBS, or Streptococcus agalactiae, which is its generic name. And the organism, it's very interesting, as we all know. It can be classified further on the basis of its cell wall polysaccharide antigen. There are 10 distinct capsular polysaccharide types. We know GBS is a colonizer. It's part of the normal flora of the gastrointestinal tract, and 20 to 30% of women can carry GBS, as we've heard, without causing problems or symptoms. Carriage in pregnant women can be consistent, or it can be intermittent. And as we've heard, GBS screening cultures are usually taken between 35 to 37 weeks, and they can potentially predict GBS, the GBS colonization state at delivery. This is the organism. I have to show this, but this is the classic, very nice looking GBS on what we call a blood agar medium. So we know that the RCOG and NICE have developed guidance, and as we know, universal screening is not offered routinely. However, it is offered according to some local protocols or patients that are at high risk. And the main risk factors in the UK are, of course, based on these 5, so prematurity, prolonged rupture of membranes, and so on. But I've added a 6th one, which is known carriage of GBS in pregnancy. And this is the 6th risk factor that is used in many European countries. So, as we know, many obstetric units follow the RCOG guidance, and 59.6% recommend a combination of the risk-based IAP and microbiological screening in women with risk factors. So, for all this, it is extremely important to have a very sensitive and also a standardized microbiological screening test. Currently, PHE offers a standard operating protocol called B58, and this is the UK standard for microbiological investigations for processing swabs for GBS carriage. If we now look at the, I would say, minimal data, it would have been interesting to have had more data from the RCOG audit in terms of microbiological screening. But from the report that's just been published, most units, unfortunately, do not use sensitive tests to detect GBS carriage. And apparently, more than 60% of them are not using what we call the gold standard method, that is the enriched culture medium. Also, the risk factors recommended by RCOG to select women for antibiotics in labour are said to be poor at predicting GBS carriage. And almost 1 in 5 women who haven't got any risk factors carry GBS. And also, very importantly, many GBS carriers are falsely given a negative result from a standard test. And this, of course, depends on many, many factors, such as the type of test that's used, the quality and time the specimen is taken. If we just very quickly just look at the procedure for microbiological screening, the first step is, of course, the sample collection. So it's a vaginal rectal swab. It is then placed into a transport medium. We normally use Amy's or Stewart's, and then it is sent to the laboratory for microbiological examination. And the standard method is the use of this enrichment broth. This is a special broth that will stimulate growth of GBS. And it's usually something like limb broth or Granada medium. From then, it is subjected to what we call selective chromogenic media. Again, very selective media for GBS. And then further tests are undertaken to identify and confirm the organism. But all in all, the minimal time taken for reporting a result is usually about 48 hours, but I would say the average would be about 72 hours. So here we have more of a description. So this is the organism from a swab to blood agar. And these are the selective media that will select out for GBS. So here we have Granada medium, where they appear as these very nice orange colonies. And here it's Strep B selective, they appear as blue colonies. And we would then go on to characterize and identify the organism by assigning it a group B, and then perhaps characterize further by assigning a serotype. Okay, we've heard about molecular screening, and I think there are pros and cons as with any assays. I first of all would like to say that many of the EOD cases, certainly this was taken from a study that was done in the States a few years ago, where they looked at the colonization of, I think, more than 3,000 pregnant women. And they found that many of the EOD cases occurred among infants of likely colonized mothers, and also amongst mothers who tested negative for GBS. So rapid testing using molecular technologies would be very, very useful in these patients, and also amongst those patients that are late entries to prenatal care or who have preterm labour. So a reliable and rapid test obviously makes it possible for the mother to be treated at the time of delivery, and obviously ensuring the very best outcome for the baby. So the use of these molecular methods, which are primarily what we call DNA amplification assays, could provide a benefit. They are more sensitive and they could minimize false negatives. But as I said, there are limitations. Some of these tests require prior enrichment, so a prior incubation stage. They need very experienced, trained staff. They need specific and often fairly expensive laboratory equipment and very strict quality control. They can be expensive to maintain. And I think very importantly, with all these tests, the isolate won't be available. So we might be missing vital information in terms of antimicrobial sensitivity, in terms of surveillance, which I think is very important, particularly with the advent of a potential vaccine. So a simple, rapid and sensitive intrapartum test is really needed. And I think this could well be addressed by some of the technologies, not necessarily molecular, that are currently being developed. Okay, so what are we doing in terms of, from the perspective of Public Health England? Well, we certainly support the current Chief Medical Officer position, and that is to enhance awareness and try and improve microbiological testing. We would provide advice, be it technical, scientific, epidemiological, and we offer a standard protocol, the B58, and this is really recommended as the microbiological method of choice for testing in laboratories. And this standard SOP is available within the 8 PHE network labs. We liaise quite closely with the RCOG and the RCM to develop educational material, and we also provide a quality assurance scheme or a panel via the UK National External Quality Assessment Scheme to ensure that appropriate standards are met within not only PHE but also laboratories. In terms of clinical audit, the UK NSC, which is part of PHE, as you know, commissioned the RCOG to undertake the recent audit of current management. In terms of R&D, you've heard we've just completed the enhanced surveillance of invasive GBS disease, and we are now developing studies to look at virulence of the organisms using whole genome technologies. Okay, I'd now like to talk to you about what we think is the largest ever pan-European screening study for GBS that we did a few years ago. And this is called DEVANI. And DEVANI stands for the design of a vaccine against neonatal infections. And this is a program which was coordinated through Novartis under the auspices of the European Commission 7th Framework Programme. The key objective of DEVANI was the design of a novel vaccine and vaccine strategy capable of inducing an appropriate and long-lasting immune response in pregnant women, which will protect their newborn babies from GBS disease. There were 8 countries within Europe that participated within the programme, and there were what we call 8 work packages. These are 8 different projects within the whole programme. So I'm going to focus on WT2 and describe the screening studies that we did in Europe at that time. So the main objective was obviously to collect data on carriage and look at the distribution of serotypes that were colonizing pregnant women. So we had 8 countries, and I think one of the main limitations of the study was the sample within each country. Some countries did screening on a regional basis. Others just undertook the screening process within one particular hospital. But at that time, this was the best we could do. If we look at screening policies in the so-called DEVANI countries, most of the countries had national microbiological screening programs in place. The only 3 countries that did the had the risk-based screening approach were Bulgaria, Denmark, and the UK. So, first of all, if we look at the study that we did in the UK, at that time it was the largest screening study in the UK, but I think the Northwick Park study that you're going to be hearing about in the next lecture has exceeded the numbers from the DEVANI study. In the UK, we had primarily 4 UK sites. We had 1 site that contributed fully to the study, and that was a site in Surrey, and we had 3 other centres that submitted swabs from high-risk mothers only, so they practiced the risk-based approach. So these were centres in Manchester, London, and also Edinburgh. So there was a lot of preparation for this study. We prepared information leaflets, posters that were put up in all the maternity units. We had to go through a very lengthy ethics process. We also had a very standard protocol that was agreed amongst all the DEVANI participants. We agreed that vaginal rectal swabs should be taken between 35 to 37 weeks. And we had a standard questionnaire for each patient to gather clinical, epi, and micro data. And all the information was from each country was submitted to an international database. The isolates from the study were then subjected to further phenotypic and molecular characterization studies, in addition to antibody studies. So this is the method that we used for screening. We used an optimal culture method using enrichment and 2 selective media. And we used a molecular method for characterizing for serotyping. This is a very simple and a very rapid tool for typing and characterizing GBS. So, just some results. Primarily, the GBS carriage rate from the centre who participated fully was in fact 27%. The prevalent capsular types were serotype 3, 1A, and 5. And all GBS pregnant women who participated in the study were given IAP. And it was interesting, there were no GBS neonatal cases identified from the main centre. Prior to the study, the average number of neonatal cases was about 6 to 8 per year. This just shows the GBS carriage rate amongst pregnant women in 8 European countries. Overall, about 22%. The highest was in the UK and also in Germany. There is a reason why Bulgaria was so low, and it really is the fact that they did have problems in terms of culture media, the types of swabs used, and transportation and expertise. These are all the issues which will affect carriage rates. Just some information on the pregnant women that were screened within the European countries. Almost an equal number had a vaginal delivery in comparison to a C-section. The maternal age was about 30, the number of pregnancies about 2, number of delivered babies was about 1, but no striking differences at all between pregnant women that were GBS positive or negative. So, just to conclude, I'd just like to say that the results are actually and finally being analysed at this time, but it really was the first ever pan-European screening study. The overall carriage rate amongst the 8 countries was 20%. If we look at the seroprevalence in all countries, the most common types were 3, 1A, 5 and 2. And all women were offered IAP. So just to summarise, it's absolutely essential to have accurate data to assess the true burden of disease and carriage. And this is, of course, very much dependent upon local policies. And I think Devani has certainly provided essential data to inform vaccine formulations. And as you've heard, there are several vaccines in the pipeline that are looking very promising. And I think Devani was also a major stepping stone for future global studies. We have proposed a study, pending funding, to look at the whole genomes or the molecular anatomy of strains from Devani to see if we can identify any biomarkers or genetic markers of virulence and potentially develop a diagnostic assay that could identify these markers from vaginal rectal swabs. Now, this BJOG debate was discussed in the session this morning, and I just thought this, the very last sentence in the argument against screening was quite interesting. That is, being able to identify women and babies who would benefit most from IAP would be an important step in balancing the benefits versus the harm of a screening program. So, is a diagnostic test to identify specific virulence or biomarkers in pregnancy, would that be the answer? Would that be the answer to overconsumption of antibiotics, anaphylaxis? Okay, I'd like to acknowledge in particular all my colleagues in the Devani Consortium, and thank you for listening.